Good afternoon, everyone. It's my absolute pleasure to introduce Dr. Negiin Pourafshar. Dr. Pourafshar is in our Department of Medicine in the Division of Nephrology and Hypertension. She started her training at the University of Florida, where she was a resident and fellow. She then moved north to the University of Virginia, where she was an assistant professor there. And she moved north again and joined us in April of this year. And we're hoping that she's going to stay with us for quite some time. Negiin has really published many first author papers on her research, reviews, and case reports. She's actually presented some of her research at our American Society of Nephrology. And again, it's my absolute pleasure to introduce her, where she'll be talking to us about cardiorenal syndrome. So Negiin, welcome to MedStar Georgetown.
Thank you. Thanks for the introduction. So as I mentioned, I'm going to talk about cardiorenal syndrome, its pathophysiology. We're going to discuss about different tools and methods for assessment of congestion. Also, we will talk about different therapeutic options for management of congestion. So I'm going to start this talk with a case that we had, and it's a fairly common case. I'm sure everyone has seen a similar one. 64-year-old male with ischemic cardiomyopathy, EF 30%, presented with shortness of breath, and baseline creatinine was 1.4 on exam. He's tachycardic, hypotensive, JVD is elevated, has crackles and bilateral edema. Creatinine is 3.16 now. So the question is that what is the most powerful predictor of inpatient mortality? Is it ejection fraction? Is it GFR or functional class of heart failure? And as we move forward, I'll go back to our case again. Congestive heart failure is the leading cause of hospitalization over the age of 65-year-old. And cardiorenal syndrome is primary disorder of heart that leads to secondary renal dysfunction and vice versa. It can develop during hospitalization and complicate therapy. A report from Asse National Registry showed that there is high prevalence of renal function impairment in heart failure patients, and it impacts the outcome of patients hospitalized with acute decompensated heart failure. And a multivariate analysis showed that GFR is the most powerful predictor of mortality, exceeding functional class and ejection fraction. So going back to our question, GFR is actually the most important predictor for mortality in these patients. And baseline renal function impairment, but not worsening renal function, was associated with increased risk of death or rehospitalization. The term cardiorenal syndrome has been applied to interactions between heart and kidney, but the definition has not been that clear. It is outlined as a condition in which therapy to relieve congestive symptom of heart failure is limited by a decline in renal function as manifested by a reduction in GFR. So going back to our case, what is the most likely contributor to worsening renal function? Is it renal venous congestion? Is it reduced renal perfusion due to low cardiac output or hypovolemia? Traditionally, what we know from medical school was that in heart failure, you see low cardiac output, and then you will see decreased renal perfusion, and that would result in renal function impairment. And that is called low forward flow. This has been looked at over the past 10 years, but no one has been able to show that there has been association with a p-value. Here you see a plot of the whole bunch of cardiac output and eGFR, and you see that there is no relationship. And here again, you see this is true among different metrics of renal function, and you see that here people in the lowest tertile and highest tertile of cardiac index, they actually had exactly the same BUN and BUN to creatinine ratio. And also a retrospective analysis of the Optime heart failure trial showed that increasing cardiac output with milrinone did not actually improve renal function when studied between the two groups. So if it is not low forward flow, then what is it? Backward failure has long been thought as a significant contributor to cardiorenal interactions. So increased renal vein congestion or renal venous hypertension has been thought to be the main determinant of cardiorenal syndrome rather than the reduced renal perfusion or neurohormonal adaptation or RV dysfunction. And here you see the prevalence of worsening renal function during hospitalization according to admission central venous pressure and cardiac index. And you see that the venous congestion was the most important hemodynamic factor driving worsening renal function in decompensated patients with advanced heart failure. Here there was an incremental risk in worsening renal function with increasing CVP or central venous pressure, but not baseline cardiac index predicted development of worsening renal function. So venous congestion is actually the most important hemodynamic factor driving worsening renal function in decompensated patients with advanced heart failure. Here you see renal venous congestion caused by intravascular congestion can lead to a buildup of renal interstitial hydrostatic pressure through the pretubular capillary congestion and development of interstitial edema. So with the increased RF pressure, the afferent pressure decrease and efferent pressure increase, therefore lowering the ability for filtration. So transmission of venous congestion to renal vein further impaired the glomerular filtration rate. We also know that there is a pre-hospitalization phase when the RV systolic pressure will increase before the patient admitted to the hospital. So it is believed that the hemodynamic congestion actually precedes the clinical congestion, and therefore hemodynamic monitoring is important to detect early sign of congestion, enabling clinician to intervene and avert hospitalization. And I come back to this point when I'm talking about different methods for congestion assessment and monitoring. But cardiorenal interactions, heart failure is complex and multifactorial. The clinician needs to sort out possible causes in an individual patient to direct therapy. They need to assess the volume status, and they need to see if there is evidence of intrinsic renal disease. So let's talk about different methods and tools that we have for assessment of congestion and hemodynamics. Obviously, history and physical exam is important. We have some biomarkers such as BNP, NT-proBNP, hemoconcentration, echocardiography, if it shows increased IVC diameter with no inspiratory collapse or increased E2A pressure showing elevated LA pressure, lung ultrasound, and bioimpedance. So I'm going to talk about some of these methods that are more recent and less commonly talked about. I'm going to show some of the evidence on hemoconcentration in decompensated heart failure population. So acute hemoglobin changes during hemodialysis have long been used to guide volume removal during renal replacement therapy. And by analogy, rising hemoglobin over a longer time interval in hospitalized heart failure patients may be a marker of diuretic response. There is no uniform definition of hemoconcentration. Some have defined hemoconcentration as increase in concentration of 2 or more of 3 intravascular substances, such as total protein, albumin, hematocrit, and hemoglobin in the highest tertile between admission and discharge. And again, there is no a specific consensus, but there are different studies on with different definitions of hemoconcentration. But here, all these studies actually shows that patients who had hemoconcentration at discharge had better survival outcome. There is also a question of timing of hemoconcentration. This is a schematic picture of volume status and hemoconcentration that I have made to show the concept of early versus late hemoconcentration. So the blue line here is volume status and red line is heme. So you see that with early hemoconcentration, patient initially gets aggressive diuresis. The volume and status improve as their hemoglobin concentration goes up. However, with too aggressive diuresis rate is more than plasma refill rate. The creatinine goes up. Therefore, we usually tend to back off on diuresis. And then the patient start to gain some fluid and their hemoconcentration becomes less. As opposed to if you gradually but steadily diurese the patient, as shown here with dashed line, there will be gradual increase in hemoconcentration, and this is called late hemoconcentration. So this conceptually shows how late hemoconcentration would be associated with better decongestion. And this hypothesis was tested in this study. They defined hemoconcentration as increase in both hematocrit and hemoglobin levels above admission values at any time during hospitalization. The timing of hemoconcentration was determined by averaging the percentage of hospital stay that had elapsed at the time of peak hematocrit and hemoglobin, then dichotomizing this value into early and late hemoconcentration by using 50% point. And they were able to show that patients who developed late hemoconcentration had actually had better survival outcomes. Several questions remains to be answered. Obviously, which marker of hemoconcentration should be used and how should it be defined? Several other factors may affect hemoconcentration during hospitalization, including subclinical bleeding, serial phlebotomy, nutritional status. So we need prospectively designed studies to help determine the clinical utility of hemoconcentration as a guide to decongestive therapy in heart failure. But I think in the hospital setting, obviously, if you have a more stable patient, we're not talking about patient with massive GI bleed. But if you have a stable patient, I think hemoconcentration is actually a practical, readily available, non-invasive, economically feasible strategy to help guide diuresis and monitor congestion relief in patients hospitalized for worsening heart failure. So I think we should strongly consider using changes in hemoglobin and hematocrit as an adjunct to other available measures of decongestion in patient heart failure care. Let's talk about lung ultrasound. So lung ultrasound can actually assess extravascular lung volume with analysis of B-line artifacts. So B-lines are a laser-like hyperechoic artifacts that arise from pleural line, extend to the bottom of the screen without fading, and move synchronously with lung sliding. And they are generated by water-thickened intralubular septa and can be seen in pulmonary edema. And the role of lung ultrasound as an adjunct to other evaluation is supported by following studies that we're going to talk about. So this is a meta-analysis, including 6 studies with total of 1827 patients. And they compared diagnostic accuracies of lung ultrasound and chest X-ray for acute decompensated heart failure patients presenting with dyspnea. And they showed that for lung ultrasound, the pooled estimates were 0.88 for sensitivity and 0.9 for specificity. And then for chest X-ray, the pooled estimates were 0.73 and 0.9 respectively. Thus, the findings suggested that lung ultrasound had greater sensitivity and similar specificity compared to chest X-ray for diagnosis of acute decompensated heart failure in this patient population. This is another study. So potential diagnostic advantage of lung ultrasound as compared to combination of chest X-ray plus measurement of NT-proBNP was suggested by this randomized trial. They had a total of 518 patients presenting with dyspnea. And they showed that initial testing with lung ultrasound improved diagnostic accuracy. Here, the area under the curve was 0.95, compared with initial clinical assessment alone with chest X-ray and NT-proBNP. So basically, they concluded that integration of lung ultrasound for diagnosis of acute decompensated heart failure seems to be more accurate. So I think bottom line is that lung ultrasound, as you know, is easy, can be done routinely. Obviously, it has some limitation. It is technique dependent and has some limited specificity. But basically, if you combine the lung ultrasound with other, methods that we have, it would be helpful for routine diagnosis of volume status in these heart failure patients. Again, it's easy to do, it's not that expensive, and it's not aggressive. Let's talk about thoracic bioimpedance monitoring or impedance cardiography, or ICG. So these are devices that measure changes in impedance across thorax and are available commercially. So blood flow through aorta is the largest determinant of the change in impedance in an individual. And with that, a stroke volume can be estimated. And this then allows calculation of cardiac index by multiplying by heart rate measured simultaneously. So here it shows that the device has 4 dual sensors with 8 leads placed on chest and neck, current transmitted through chest. ICG measures baseline impedance to current, and with each heartbeat, blood volume and velocity in the aorta change. ICG measures corresponding change in impedance and uses baseline and changes in impedance to measure and calculate hemodynamic parameters. The role of ICG in evaluation of volume status in acute decompensated heart failure was studied in bioimpedance cardiography in advanced heart failure, or big sub-study within the ESCAPE trial. So they compared ICG with invasively measured hemodynamics by simple correlation and compared overall ICG hemodynamic profiles versus those determined by invasive measurements. And they showed that there was a modest correlation between ICG and invasively measured cardiac output. So again, there was a modest correlation, but it didn't provide information on ventricular filling pressure. But here we are talking on this study on decompensated heart failure hospitalized patients. But it could be actually used, the ICG could be used routinely in more stable clinic patients as well. Given the limitations of non-invasive assessments of hemodynamics, it is not actually surprising that invasive measurement is often undertaken with right heart catheterization. But the question was that how often the right heart cath should be done, and if routine use of right heart cath would improve the outcomes. And this was studied in a ESCAPE trial. They randomized patients to optimal medical therapy by clinical assessment alone and combination of clinical assessment and invasively measured hemodynamics. And they actually showed that there was no significant difference in primary outcome, meaning number of days alive outside the hospital at 6 months post-randomization between the two groups, as you see here. Here's a meta-analysis which included the ESCAPE trial and showed that effect of right heart catheterization on outcome was neutral. So routine right heart catheterization in patients with decompensated heart failure is not actually justified. But again, I emphasize on the routine use. However, invasive hemodynamic monitoring is recommended for patients with acute decompensated heart failure with persistent symptoms and when hemodynamics are uncertain. In addition, it could be useful in carefully selected patients with persistent symptoms despite standard therapies and in patients who have worsening renal function with therapy. But again, the routine use of the right heart cath is not currently recommended, but it should be individualized based on the patient's clinical status. Another technological advance has been development of implantable devices to assess volume status on an ongoing basis. And this is the Cardiorenal transmitter implanted in pulmonary artery. We actually had this device at UVA, and we had common patients in heart failure clinic and nephrology clinic with this device. So this little system will be implanted in pulmonary artery with right heart catheterization. Once the sensor is implanted, they would be able to take pulmonary artery pressure readings at home, and then the pressure would be sent to physician, and then physician, based on the peer pressures and pulmonary artery pressure reading, can adjust the medications. The Champion trial reported on outcomes from care based on peer pressure measured by an implantable PS sensor. They randomly assigned patients to management with wireless implantable hemodynamic monitoring or to a control group for at least 6 months. And then they were able to show that patients randomized to PM monitoring had significant 30% reduction in hospitalization in the 6 months following randomization. And this was the first large trial to demonstrate improved outcome with an implantable monitoring device. Recently, 2 post-marketing surveillance studies confirmed treatment benefits in reducing a number of heart failure hospitalization and showed significant improvement in quality of life with the Cardiorenal system. In addition, the sensor safety and durability were comparable to the findings in the Champion trial. Here they showed that freedom from device-related complication at 12 months, and here it shows freedom from sensor failure at 12 months. So again, the device is safe and durable and improves outcome. So Cardiorenal have changed the landscape. And the struggle, I think, is now to make this technology accessible. As I mentioned, there are some institutions in United States and Europe that have been using this technology. And I think it's easy to place it technologically, but the main issue is having the infrastructure to read and manage the data frequently, call the patients, adjust the medications on ongoing basis. But again, all the trials and data that we have on the Cardiorenal transmitter have been positive and showed improved outcome. Going back to our case, patient was started on Bumax strip, there is negative 2 liters. Creatinine actually further worsened. Patient is still short of breath. So what do you think would be the next step? Do you want to stop Bumax strip as you have over-diuresed the patient? Do you want to continue diuresis or ultrafiltration? And here's the echocardiogram that shows the dilated IVC and also elevated E to A ratio. So the patient is volume overloaded and clinically he's short of breath. So let's talk about management of congestion. A standard therapy has not significantly changed, unfortunately, and since 1970s actually, and includes diuretics and variable use of vasodilators or inotropes. So you give loop diuretics, you give more loop diuretics, sometimes you add thiazide diuretics and adjunctive vasodilators, and there is always question of ultrafiltration. So I'm going to show some evidence on different therapeutic options that we have available. So we're going to talk about some landmark studies on different management strategies. This is the DOSE trial to evaluate the safety and efficacy of various initial strategies of furosemide therapy in patients with acute decompensated heart failure. They compared route of administration Q12-hour bolus versus continuous infusion and high dose versus low dose. So here they showed that there was not much difference in high dose versus low dose. High dose was associated with some improvement in clinical measures, but again, not significant difference. It had more transient worsening renal function, but transient worsening renal function in hospital didn't adversely affect the 60-day outcomes. Also, trial evidence didn't support meaningful superiority of infusion versus bolus, and infusion may be actually less effective in diuretic resistant patients. It could cause worsened structural remodeling of distal tubule and worsened diuretic resistance. And the issue of the diuretic resistance is actually one of the main clinical challenges encountered in achieving effective decongestion in subjects with cardiorenal syndrome and acute decompensated heart failure. So chronic administration of loop diuretic induces hypertrophy and hyperplasia in epithelial cells of distal convoluted tubule, leading to an increased reabsorption of sodium in this segment, thereby blunting the natriuretic effect. Therefore, again, this problem of diuretic resistance is commonly seen in heart failure patients with long-term use of diuretics in these patients. How about other adjunct therapies? One of them is nasiritide that was studied in Ascent heart failure trial. This is a recombinant form of human B natriuretic peptide and works through counter-regulation of renin-angiotensin aldosterone system, stimulating CGMP and leading to a smooth muscle cell relaxation. But the Ascent trial showed that nasiritide was not associated with an increase or decrease in rate of death and rehospitalization, and had a small and significant effect on dyspnea when used in combination with other therapies. Another medical therapy was vasopressin antagonist. So this is the Everest trial, which studies the effect of tolvaptan, which is a selective vasopressor antagonist and causes production of very hypotonic urine. And the trial showed that while it improved dyspnea, edema, and body weight in short term, but it did not reduce all-cause mortality, cardiovascular death, or rehospitalization for heart failure. So if you look at these two curves, here the solid line shows the treatment group, the dashed line shows the control group, and you see these curves cannot be more overlapping. So I'm not going to show you all these negative trials, but the point is that none of these therapies have actually shown improvement in solid cardiovascular outcome measures in acute decompensated heart failure. And again, the focus of this talk is acute decompensated heart failure patients. But there are, since these trials are fairly new, I wanted just to show you there are emerging therapies that has been beneficial in chronic stable heart failure patient. Paradigm trial studied the effect of Entresto. We have DAPA heart failure, studied the effect of SGLT2 inhibitors. And this is the vericiguat, which is fairly new. This is a CGMP stimulator. So these medications are promising in the field, but again, these are for more chronic, stable heart failure patients, but not acute decompensated hospitalized patients. So far for those acute decompensated heart failure patients, we don't have optimal therapeutic option for effective diuresis in these patients. How about the role of mechanical decongestion? Ultrafiltration is an extracorporeal technique on the principle of convective solute transport. an ultrafilter of plasma composed of water and a smaller solute produced by exerting hydrostatic pressure across a semi-permeable membrane. And the concentration of solute is similar between the serum and ultrafiltrate. So basically, if we compare diuretics and ultrafiltration side by side, here are some advantages of ultrafiltration. With ultrafiltration, you don't have direct neurohormonal activation. You can have removal of isotonic plasma water. You can have precise control of rate and amount of fluid removal. And you can have restoration of diuretic agent responsiveness, and there is no effect on plasma concentration of potassium and magnesium. But obviously, you will need an access, you will need extracorporeal circuit, and you may need anticoagulation. So ultrafiltration provides more rapid, adjustable, and predictable fluid and sodium removal without the risk of development of refractoriness. And it doesn't affect the plasma concentration of solutes and is not associated with electrolyte imbalance and their downstream side effects. I'm going to briefly talk about some of the landmark trial on ultrafiltration. The first trial was the rapid heart failure trial, which was a small study proof of concept trial. And they showed that it didn't reach the primary outcome of weight loss, but it reached the secondary outcome of fluid removal, as you see here at 24 hours. This led to the UNLOAD trial. They had 200 patients. I think it is important that if you look at the inclusion and exclusion criteria here, because we will be back to this, but you see that some key point is that basically patients with elevated creatinine over 3 were excluded. Hypotensive patients, patients with acute coronary syndrome were also excluded in this study. But the study showed that the US strategy was associated with higher fluid removal and weight loss at 48 hours. And there was no significant difference in renal function during the duration of the study. The key finding UNLOAD excited everyone was that it was the first study that showed ultrafiltration reduces heart failure hospitalization. This, I would say, the best clinical outcome that UF trials have shown ultrafiltration would achieve, with 44% relative risk reduction at 90 days. This led to the most controversial studies in ultrafiltration, which is CARES heart failure trial. It's important to know that they have a stepwise pharmacologic therapy in CARES heart failure. Obviously, this slide is not meant to be read, but it just shows that this study, as opposed to UNLOAD, which had a very vague protocol, they had a stepwise approach, how you medically treat these patients, and what dose of diuretic use based on their urine output, when to add inotrope, when to add vasopressin. They defined a primary bivariate outcome of serum creatinine level and body weight at 96 hours. And the reason they combined these two outcomes was if one is improving at the expense of the other one, they would neutralize each other's effect. And they showed that at 96 hours, UF was associated with a worsening kidney function, as you see here, which was statistically significant, but the change in body weight was not significant between the two groups. But why CARES heart failure didn't produce the favorable results of the prior randomized control trial? It should be noted that in the UF arm, the use of inotropes and vasodilator was prohibited, whereas they were permitted in the stepwise pharmacology therapy group. And while UF was performed at a fixed rate and not customized to the clinical status, dosing of diuretics was adjusted in the stepwise pharmacology therapy arm based on the therapeutic response. And there was no continuous monitoring to avoid too rapid or too large fluid removal. And therefore, we had the next study, which is Avoid Heart Failure trial. The design of Avoid Heart Failure addressed an important shortcoming of previous landmark studies. The UNLOAD trial compared an efficient UF therapy with a suboptimal medical regimen and reported superiority of ultrafiltration, while CHARES Heart Failure compared a suboptimal ultrafiltration therapy with an effective pharmacologic regimen and found medical management superior. So taking these experiences into consideration, Avoid Heart Failure sought to compare optimized medical therapy with an adjustable UF therapy. And the primary endpoint was defined time to first heart failure event within 90 days after discharge. So again, here, this slide is to show that they had algorithm for medical therapy arm, and also they had algorithm for ultrafiltration. So this is their advantage over the previous studies. The UF group, they showed that the UF group had higher percentage of patients free of heart failure events. The curves are separate, but the difference did not reach a statistical significance with a p-value of 0.106. But the authors attributed the non-significant p-value to the small sample size. They had about 100 patients in each arm, as they had recruited less patients than initially planned. However, you see circled are secondary outcomes that are actually statistically significantly different, and UF showed benefit, which include number of patients with heart failure rehospitalization, total number of cardiovascular rehospitalization. So these secondary endpoint, actually ultrafiltration therapy showed some benefit. But if you ask about use of ultrafiltration, there are still knowledge gaps in the use of ultrafiltration in heart failure. If you look at all those landmark trials, baseline creatinine on all landmark studies was 1.5 to 1.9, and serum creatinine of 3 or more has been an exclusion criteria, actually. So when nephrology is consulted for ultrafiltration in this acute decompensated heart failure, which have more severe renal dysfunction and congestion, there is simply no evidence in the literature how it affects their overall outcome. And to date, if you look, all these studies relied on clinical signs and symptoms of fluid excess, which could be actually problematic due to the poor correlation between clinical assessment and objective measures of filling pressures. So the conflicting result from these ultrafiltration studies highlights the fact that the patient selection and fluid removal targets are actually incompletely understood. So ultrafiltration therapy seems to be more beneficial if applied with a flexible regimen to allow customization of procedure to the therapeutic needs of each patient. Adjustment of ultrafiltration rate to patient's vital sign and urine output associated with more effective decongestion and fewer heart failure events. But as we mentioned, future trials should evaluate whether the greater cost of mechanical fluid removal during the hospitalization is offset by savings from potentially fewer heart failure events in patients treated with ultrafiltration. So again, if you ask me about ultrafiltration, the common recommendation or practice is that usually we use ultrafiltration when the diuretics fail and you see significant renal failure. However, I want to put emphasis on that, as mentioned in all the studies that are done in ultrafiltration, patients with elevated creatinine over 3 were actually excluded. But in my opinion, the best publicly available protocol for fluid removal would be the algorithm used by Avoid Heart Failure trial, because they had individualization of fluid removal rates based on, as we mentioned, the blood pressure, the renal function, and the urine output, and they didn't use fixed rate. They actually had adjustable UF rate. But let's go back to our case. So despite IV diuresis, the patient creatinine continued to increase. Symptoms mildly better, but had low blood pressure to begin with, as we saw. But initially, there was a thought that maybe worsening renal function was due to overdiuresis. But we did the lung ultrasound, which showed B lines in all examining scan zones bilaterally, suggesting significantly elevated extravascular lung water. And then patient underwent right heart cath, which showed elevated pressures. Therefore, he had intensification of diuretic therapy and inotrope support. Eventually had symptom improvement, and creatinine was better at discharge, although not back to the baseline. But through this case, again, this case is fairly common. I'm sure you have seen a similar one, but I would like to mention a few points that we discussed. First, to convey that lung ultrasound is a valuable adjunct to conventional clinical exam parameters in patients with heart failure. Also, the role of right heart cath in acute decompensated heart failure. Again, as I mentioned, the routine use is not recommended, but in those patients with persistent symptoms and when hemodynamics are uncertain and when you see worsening renal function, right heart cath could guide you on the volume status of the patient and guide us to further management. Also, it needs to be mentioned that recent findings support the aggressive decongestion-mediated increased creatinine, which may be reflecting hemoconcentration, as we discussed, which is associated with decongestion and clinical improvement. So increased creatinine that follows effective fluid removal and hemoconcentration may be associated with improved outcome. So again, the bottom line is that when you have a patient with decompensated heart failure, you're treating the patient with diuretic therapy, the creatinine goes up. We shouldn't be scared of the creatinine level. If you feel that the patient is clinically volume overloaded, and again, we have some adjunct tools to guide us through the volume status of the patient. And if we decide that the patient is still volume overloaded, we definitely need to manage the volume overload and then follow the creatinine level. And as I mentioned, the transient increased creatinine level during the hospitalization may not actually show the renal injury, but actually show the effective decongestive therapy. So to summarize this talk, congestion has a very important effect on heart failure outcome, and it is often undertreated. Different methods developed for assessment of congestion in heart failure patients to guide us on appropriate management. And a significant proportion of patients develop an inadequate response to diuretic agent therapy. Other pharmacology therapy have not improved the outcome acute decompensated heart failure patients. Ultrafiltration is an attractive alternative therapy to predictably remove total body fluid and sodium. It should be adjusted to the patient's hemodynamic. Fluid removal amount, duration, and rate should be guided by objective measurements of volume status. And with that, I conclude this talk, and I would be happy to answer any questions.